Hey everyone, in this video I'll be going through the signs seen in intoxication and withdrawal in different substances. My goal for this video is to mention the specific sign of intoxication or withdrawal and then leave a second for you to think about what might be causing that specific sign. First off, we have yawning. Yawning is associated with opioid withdrawal. Next, we have pinpoint pupils and CNS depression. This is seen in opioid intoxication. And remember that the primary treatment for a patient who is overdosing on opioids is naloxone, which is also known as Narcan. Next up, we have dilated pupils, and there's three possible options here. So we have cocaine intoxication, amphetamine intoxication, and opioid withdrawal. One thing I wanted to point out is that we just mentioned that opioid intoxication causes pinpoint pupils. So you just want to think about what would be the opposite if we were to consider withdrawal from the opioid. So if intoxication causes pinpoint pupils, withdrawal would cause the opposite, which is dilated pupils. Next up, we have tactile hallucinations. There's two possibilities here. These are cocaine intoxication and methamphetamine intoxication. For this next one, I want you to consider this picture. So the dental findings seen here are commonly referred to as meth mouth, which is caused by methamphetamine. Next, we have violence, impulsiveness, and vertical or horizontal nystagmus. This is PCP intoxication. When it comes to treatment of PCP, you can generally just provide reassurance to the patient and supportive therapy, but for cases that are very severe, you can consider benzodiazepines and haloperidol. Bruxism, hyperthermia, and hypertension seen in a patient attending a rave. This is MDMA or ecstasy intoxication. So I think the two main things to look out for here are bruxism and the fact that the patient is attending some sort of a rave or a party where MDMA use can be prevalent. And an important association to know with the MDMA is that it causes a huge increase in dopamine and serotonin release. Next up, we have increased appetite, dry mouth, and conjunctival injection. This one's pretty straightforward. That's marijuana intoxication. Next, we have constipation. This is opioid intoxication. Trouble concentrating and headache. There's two options here. Caffeine withdrawal and nicotine withdrawal. So obviously, trouble concentrating and headache can be seen with a bunch of different substances, but in the absence of any other signs and symptoms or any other information associated with the patient, then caffeine withdrawal and nicotine withdrawal are safe bets. Perceptual distortions, both auditory and visual, depersonalization, anxiety, flashbacks. This is LSD intoxication. So 48 to 72 hours after stopping a substance, the patient begins to experience tremors, confusion, hallucinations, seizures, and high blood pressure. This is delirium tremens, which is caused by alcohol withdrawal and occurs 48 to 72 hours after they stop drinking alcohol. And the goal here is to treat this patient aggressively with hydration and benzos. Very important because it's life-threatening. Diarrhea, piloerection, and sweating. This is associated with opioid withdrawal. So I want you to remember that we said opioid intoxication is associated with constipation. So the opposite of that would be withdrawal, which would lead to diarrhea. A crash with severe hypersomnolence, depression, hunger, and dreaming. This sounds a lot like cocaine withdrawal. A patient with a history of bipolar disorder who presents with ataxia, tremors, and hyperreflexia. So what I'm trying to get at with this question is that this is a patient being treated for bipolar disorder, and as a result of that treatment is experiencing these signs. So this sounds a lot like lithium toxicity. Lithium can lead to various GI and neuro side effects. And a lot of those side effects will be seen at a level of lithium that is greater than 1.5. A patient with a history of depression who presents with anticholinergic symptoms, respiratory depression, and an ECG showing a QRS greater than 100 milliseconds. So this is TCA toxicity, and I think all of these are very helpful in identifying this, but especially the anticholinergic and then the QRS greater than 100. The treatment here is sodium bicarbonate. A patient with a history of depression who presents with altered mental status, fever, myoclonus, diarrhea, and hyperreflexia. This is serotonin syndrome, so lots of signs to look out for here, but especially the myoclonus is a good one. It's a great buzzword. So the consideration with serotonin syndrome is that it's basically caused by two or more drugs that are serotonin enhancing. So this happens a lot of the time in patients who take a SSRI and a monoamine oxidase inhibitor. The treatment with serotonin syndrome is to discontinue the offending agents and then offer benzos, or if it's really needed, then cyproheptadine. Anxiety, irritability, decreased appetite, and insomnia. Kind of vague signs and symptoms here, but this would be representative of marijuana withdrawal. Perioral rash, ataxia, and tremor in a patient with a history of polyneuropathy in the lower extremities for the past year. This is inhalant toxicity, so it's very important to be aware that inhalants will eventually cause polyneuropathy because they will lead to a B12 deficiency. Grandiosity, skin excoriations, pupillary dilation, and poor dentition. This is meth intoxication. Restlessness, muscle twitching, and arrhythmias in a college student. This is caffeine intoxication. Agitation, combativeness, and psychosis that can last for weeks and is not detected on routine urine screen test. This is bath salts, so what kind of gives it away is the fact that the symptoms have lasted for weeks. That long period is indicative of bath salts. Drug withdrawal that is life-threatening, so 3 options here. Alcohol withdrawal, benzodiazepine withdrawal, and barbiturate withdrawal. Drug intoxication with the highest risk of respiratory depression. This is barbiturate intoxication. So 2 scenarios here. First is pupillary dilation, grandiosity, hypertension, and paranoia that lasts for several hours. The next is pupillary dilation, grandiosity, and vasospasm that lasts for a shorter period. So the first one that lasts for several hours is actually amphetamine intoxication, and the scenario that is a shorter period, which is around an hour or less, is cocaine intoxication. So the timeline is definitely something important to consider. I hope this rapid review was helpful. If you have any questions, please feel free to leave them below.